think we'll go ahead and get started. We just have a few people on right now, but I suspect some others will start. We always record these talks, so you're welcome to look at them at any time. Highly recommend that if you want to pass the boards. So basically today is where I kind of go through a series of cases and just kind of give you a professor's view of how I approach these and what I do when I'm looking at cases every single day. We just finished looking at a few hundred cases this morning prior to this. So we'll get started. Okay, so we have a shave biopsy. And, you know, when I'm reading cases, I'm looking at things and usually just kind of making what seems to people looking while I'm reading this instantaneous diagnosis. But what I'm really doing is going through the same criteria that I'm saying here, only it's sort of in slow motion now. So I've been doing this for so long, I can look at this immediately and say what the diagnosis is, but you haven't. And so you need to basically slow down, start from scratch, go through the steps that I'm going to go through here with you in a very systematic way, and then arrive at a diagnosis. Because when you're on a board examination, they know that some people have a tendency to just kind of look at something and make a quick diagnosis. So they're going to put something in there that says, well, this might throw them off. You know, the unaware might choose this, because I've written questions for the board. I've submitted histologic specimens for the pathology part of the board examination. So I've done it before, so I know what they're thinking. So I've kind of been on the other side of the table, so I can give you the ways that they're thinking about this too. It's a fair test, so they're not trying to do something that's unfair, but they are trying to make sure that you approach things in the way that a rational and reasonable dermatologist and dermatopathologist, if you're taking the derm path boards, would do. And so we want you to go through these steps. We want you to take the time. You have plenty of time to go through the steps and apply the criteria and then make a diagnosis. So we have a shave biopsy. Looks like it was probably some kind of a sessile papule. Can't tell precisely what part of the body it's on, but clearly it's not on palm or sole or mucous membrane or anything like that. It's got some, maybe at low power, there's some bluish gray material. Maybe it's on sun-damaged skin. We'll see that when we go to higher magnification. And then, of course, the first step we ask ourselves is whether we think it's inflammatory or neoplastic. And, you know, that probably covers about 80 to 85% of all the entities in dermatology and dermatopathology. There are a few other sort of exceptions to the rule, little outliers, like, you know, deposits and pigmentary disorders and things like that. Are those really inflammatory, or are they really, you know, neoplastic? So they don't always fit in. But this is, you know, we want to keep it simple. So when taking the board exam, you know, we're not trying to make you into a board certified dermatopathologist. We're trying to just make sure you're responding as a reasonable dermatology resident would under the circumstances to be able to make appropriate diagnoses. So you'll understand when you're in practice, clinical pathologic correlation. So anyway, it's a neoplasm. As you can see, and why? Because you can see that there are, and this sounds tautologic, but there are obviously neoplastic cells here. If we see only inflammatory cells at low magnification, we say, well, it's probably inflammatory, although we can see lymphomas and things like that have inflammatory cells, but they're neoplastic conditions. But we can see that these are clearly not lymphocytes, neutrophils, anything like that. So that's really the answer. You say, well, is it inflammatory or neoplastic? There are non-inflammatory cells in the lesion. So we know it's got to be a neoplasm of some sort. The next question is whether we think it's benign or malignant. And we use our typical criteria. Is it broad, asymmetrical, poorly circumscribed? Those are signs of low magnification, architectural features of malignancy. This thing looks relatively small. We took a shave and probably got 90% of it out. And if you draw a line down the middle of it, it pretty much looks the same in one side as it does the other. Now, another thing you can do is look at the individual aggregations of cells. So if you have just a part of something and you can't really apply those criteria, you can look at the individual aggregations that are comprising the lesion. So almost like if you're looking at a jigsaw puzzle, you're looking at one piece of the puzzle. If you don't have the entire puzzle, and then you try to sort of say, well, that looks small, symmetrical, well circumscribed, so it would favor benign based on that. But here we do have something that we can tell. It is quite We got 90% of the lesions, so we think it's relatively small, maybe only about a couple of millimeters in size, 3 millimeters or so at most, symmetrical. And then the next question is it epithelial or non-epithelial? Okay, so again, keeping it simple, non-epithelial, we think of three things, basically: neural, muscle, fibrohistiocytic. And those are usually spindle cells. And at low magnification, you can see, well, this is not spindle. There's no way this is a spindle cell process. So it's going to favor epithelial, not non-epithelial. Okay, so epithelial, benign epithelial. And then we've got to say, well, what kind of epithelium? You know, there's more than just one kind of epithelium that lives in our skin. You know, the main epithelium we think about is the stratified squamous epithelium of the epidermis, but there are a lot of other epithelial structures in the skin. You know, there's hair follicles, there's sebaceous glands, there's acrine glands, there's apocrine glands, there's so there's a whole lot of glandular tissue as well, and that's also epithelial in nature. So we have to ask ourselves which type of epithelium. And so we start looking, and we see that there are these little cysts here. So that's important. We see that there are these blue areas here. So when we see something blue that's epithelial, that makes us think of basaloid. Okay, and obviously when we think of basaloid, we think of the basal cell layer of the epidermis, the stem cell layer of the epidermis, which also those same cells are associated with the germinative cells of a hair follicle, the papilla of the follicle, or the mantle zone of the follicle. Those also have the little basaloid bluish cells, germinative cells of a sebaceous cell, for example. So those are other things we think about. And then, in order to really sort of define the type of epithelium, you have to know the basic normal anatomy of the structures of the skin. So the hair follicle, for example, has got three components, really four, but three main ones. It's got the superficial infundibulum, like you see right over here in this part. That's the infundibular part of the follicle. Then there's the isthmus of the follicle, which is between the infundibulum and then the inferior portion. That's where the mantle zone lives. And that's a stem cell component that can give rise to little hamartomatous lesions. And then, of course, there's the inferior portion that looks like the hair bulb. And so look at this. We see all of those here. Here's a hair papilla that's being recapitulated in this lesion. Here's an infundibulum that's being recapitulated in this lesion. So it's like a little small cyst, like an infundibular cyst. So we have all of these small little aggregations of these primitive hair follicle structures that are present in this lesion. So this is a benign epithelial neoplasm with follicular differentiation. Okay, so you're about 90+% of the way there when you get to that point. So that's the good news. Then you have to have a little bit more sophistication to take it all the way over the goal line. So you have to say, well, okay, now that we know that's follicular, what else can we use for criteria to kind of help us make the diagnosis? And if you see structures like this that are obvious, well, they're primitive, they're obviously hamartomatous, but you can make out that these are hair follicles here. There's a little mini hair follicle sitting right here. You've got the little cyst-like structures. You've got this little area over here that looks like it kind of came off the mantle zone, these little sort of reticulated follicular structures right in here that are primitive as well. And then we've got a very prominent fibrous stroma with no clefting between the epithelial components and the stroma. You see the clefting is occurring within the stroma itself. And so when we can tell what kind of follicular structures are present like this, and they look like little mini follicles like this over diffuse nodular structure like we see here, that's pretty much diagnostic of a trichoepithelioma. So this is a classic example of a trichoepithelioma. It doesn't really look much like a basal cell carcinoma in this lesion. Sometimes they can, but in this situation, no. Now, one game I sort of like to play with our residents and others that rotate with us is that when we look at one of these, we say, okay, well, let's pretend like you're writing a question for the board examination and you want to try to trip up the examinee. What other potential things are you going to throw in the differential diagnosis to try to trip them up? So they're not going to put something sort of bizarre like something like a trichoblastoma. There's no controversy on the board examination. They don't like that. They've had lawsuits in the past. They don't want to put anything controversial. They're going to put something that's straightforward, it's reasonable, that any good, well-trained dermatology resident should be able to answer, and they shouldn't argue with the diagnosis, so it should be pretty straightforward. So they're not going to put something under and say, well, this could maybe be a funny trichoblastoma with trichoepitheliomatous features, or a trichoepithelioma variant of trichoblastoma. No, and don't go down that rabbit hole either. You want to stick with what's obvious. So they're not going to do that. But they might put on there a trichofolliculoma, okay? And so you might start looking at this and say, well, hey, there's a little cyst here, and there's a little radiating follicular structure from the little cyst here. And, that's what we have learned, and we're reading our textbooks that you can see in a trichofolliculoma. So maybe I'll put that down. Well, don't be fooled, because that's just one small focus within the remainder of the entire lesion that looks like a classic trichoepithelioma. That's a classic test-taking strategy that test producers, test writers, question writers put on there, is say, let's put a small criterion in there, one thing that they'll choose because they just jump to the conclusion that it's this because one small focus of it's that, where the rest of it is an obvious example of a trichoepithelioma. So don't fall down that pathway. They're not going to do that. They might put basal cell in here. That would be very reasonable to put that as a choice, because it's clearly is not a basal cell. They probably would not put something like a benign follicular hamartoma, because that's sort of a generic term that can show several different features. I mean, it's not really usually used synonymously with this, but I doubt seriously they would put that on there. They'd probably put something like maybe a trichofolliculoma, or maybe a trichoadenoma, which is mostly just all cysts with none of these more primitive follicular elements to it. They could possibly put something like a nexal tumor, like a cylindroma or spiroadenoma, that somebody that's like been comatose during their residency might choose something like that. So anyway, just make sure that you apply the criteria, you know what you're looking for, and you'll be good when you actually encounter this on the exam. My goal is to have you, when you get on the exam, for your heart rate not to rise more than 2% when you look at a slide. I want you to be calm, collected, no problems when you get on this. Okay, this one. Now, I apologize a little bit for the slide. There's a lot of garbage and gunk on the top of it, but that's actually commonly seen in this entity. So we're going to focus on this area. I did a shave biopsy of this. And clinically, it's got all this goo at the top, because these lesions are often oozing and weeping and crusting when you see them clinically. And you look at them across the room, patient comes in with this oozy, crusty thing on their scalp most commonly, and the clinical diagnosis is usually, oh my gosh, this looks like a squamous cell, so it was really, really bad. And so they take a biopsy of it, and the good news is it's not a squamous cell. But this is a fairly common phenomenon on the scalp. You get all this crusting and thick cornified material and scale crust. And so somebody comes in and they take a biopsy, and unfortunately, a lot of times this is all we get. We just get this junk, and they don't get down deep enough into the epithelium. So when you're dealing with a patient who's got a scalp lesion, you've got to take a healthy piece of that skin, or you're liable to miss the neoplastic process. So crusting, it takes up a significant, part of the specimen there. I mean, it can be like a millimeter thick. So you got to cut through a millimeter of garbage before you finally get down to the neoplastic process. And so the same thing is true on volar skin, where you got a thick cornified layer. A lot of people send us biopsies to rule out melanoma, and they send us only the cornified layer because they hadn't gone deep enough. Maybe the patient barely bleeds. So you have to get down in, and you have to see that you're cutting into the papillary reticular dermis, or you're not going to get an adequate biopsy of something like this. So once again, we've got a neoplastic process, and it's kind of cut funny. I think this looks like the outer part of it over here, but you can see over here you got what looks like the outer part of it over here. So it might have been kind of almost a pedunculated or sessile lesion that's got some normal epidermis kind of on both sides of it. But this is where the action is, if you will. And at low power, once again, we see that this is epithelial. And this time it looks a lot, at least at low power, like it may have some squamous epithelial component, or certainly the epidermis is thick. And then we got something going on over here that's abnormal. And that's what's contiguous with all this purulent crusted material that we see up in here. Let's go to higher magnification, and you've got a shave of it. So unfortunately, we don't have like we did before where they shaved off the entire lesion. So we can't really apply breadth, symmetry, and circumscription as easily in a lesion like this. We're going to have to use other criteria to tell us whether it's benign or malignant. But at least when we look at it, it seems like over here, it kind of comes to a stop at this edge. We don't know about over here. This seems like it's going superficially, like it's almost an exogenous process as opposed to an endophytic process. So that might be somewhat helpful because we know that when things tend to be more deep, bottom heavy, that favors malignant versus when something's kind of superficial. So anyway, it might favor benign, but we're a little bit compromised because we just have a small piece of it. We're going to have to use some additional criteria here. We think it's probably going to be epithelium. And then at this power, you can also see it's got these multiple little almost fronds associated with it here. So it's got a papillomatous component. Papilla basically means, it comes from the I think it's the Greek word for nipple, pap. So basically it's like multiple little nipples here. So it's papillated, if you will, if you see here. So that's helpful. And then as we go to higher magnification, I'm going to look and see if we can tell anything more about the differentiation. And you can see that it is epithelial. And anytime you look at an epithelium, you want to see what kind of epithelium it is that you're looking at. And this it's got features of apocrine differentiation. You can see that there are these areas of decapitation secretion. Okay. You've got this is almost like an apocrine duct here that's contiguous with this. You've got lots and lots of plasma cells in the stroma, which is helpful in the diagnosis of this entity. And so this is a classic example of a Syringocystadenoma Papilliferum. And that's a pretty good name. It's a pretty good name. Syringo means duct, okay. Syringocystadenoma, okay, well, it's an adenoma, which is a benign glandular neoplasm. It's not too cystic, but it's maybe these are little small cyst-like structures that are lined by apocrine epithelium, but it's definitely papillomatous. So it's got the papilliferum component to it. And this is a classic example of that. They usually occur on the scalp. The most common setting where we see them is in association with nevus sebaceous. We do not see a nevus sebaceous this time. That could be because it was a sampling error and they didn't hit the nevus sebaceous component, or it could just be that they only have the Syringocystadenoma Papilliferum without the nevus sebaceous, which can happen also. So this is a benign adnexal neoplasm with apocrine differentiation. And make sure when you're looking for something for apocrine differentiation, you can identify the decapitation secretion that we see with apocrine. It's really nice over here. You see the little apocrine secretion within the lumen of that little duct area right there. And then the abundant plasma cells are seen as well. Lots of plasma cells, very common to see that in this entity. Now, there's a couple of other things that can simulate this. If you take this same lesion and move it to the groin area and make it more invaginated with a superficial erosion to it, it looks exactly the same with a different architecture, and we call it a hydranoma papilliferum. So it's basically the same entity, different location, different architecture. Boom, same sort of thing. If you take the same sort of lesion and stick it on the breast, and it's more kind of endophytic, but they still get sort of an erosion a lot of times, and it kind of looks a little bit like a hydranoma papilliferum. We call that a nipple adenoma, or erosive adenomatosis of the nipple. And that's also got apocrine differentiation. The breast is a giant apocrine gland, basically. If you look at breast glandular tissue, it basically looks just like apocrine tissue. So it's basically, obviously now a structure that's secreting milk, but basically it ultimately comes from apocrine cells originally. So it's basically a similar kind of analogy, same sort of thing. So those all are sort of in the same family. But just make sure you understand what this looks like. And in the most common setting where we see it is in association with nevus sebaceous. We don't see that this time. Now, just so happens, we've got a similar kind of phenomenon here. And I just mentioned this to you a second ago, interestingly enough. We've got a dome-shaped papule this time that's also quite symmetrical, very well circumscribed, so we favor a benign process here, and epithelial. And as we go to higher magnification, it's got a lot of verrucous epithelial hyperplasia. This one's you're not going to get on the board examination because this is really a more difficult and challenging thing. But if you start looking in this area right here, these zones right here, guess what we see once again? We get these cells that have the apocrine differentiation to them. Okay, it's got a couple of mitotic figures in here, but that doesn't mean that it's malignant. And this was also on the breast. So this is a similar kind of phenomenon that I just mentioned to you before. This is a nipple adenoma or erosive adenomatosis of the nipple. Same sort of idea. It's more endophytic here. This one's got a lot of warty pseudocarcinomatous hyperplasia, which you don't always see that in nipple adenoma. A lot of times it's just only this glandular epithelium here. So this is an example of a nipple adenoma. Now we kind of put this in here mainly just kind of for contrast and to kind of show you the fact that it's in the same family as Syringocystadenoma Papilliferum. Can you see the apocrine differentiation here? You see the plasma cells. You see the papillomatous component of it. It looks, if you just saw this at high magnification and sort of transposed it on the Syringocystadenoma Papilliferum or Hydroadenoma Papilliferum, you'd say that it basically it looks the same. So it's kind of the same type of process with just different architecture. And, we see that in a lot of different settings in dermatopathology. We see that in the focal acantholytic disc keratosis situations where we see warty disc keratoma and Grovers and Darias. They can all kind of have the same sort of reaction pattern, but there's different architecture, different clinical presentation. So that's basically what's going on here. Nipple adenoma. Now, you're not going to get this on the exam. I'm not going to show it to you, but we just basically wanted to show you this as an example. It's kind of interesting because this one's got all this verrucous hyperplasia, which is a little bit unusual. You don't always get that. Sometimes you just see only this component to it. And this one had a couple of mitotic figures. So whenever you see anything on the breast, obviously you sort of, want to make sure that it's not something more nefarious. The one thing about any kind of adnexal tumor of any kind, any large or solid kind, I wouldn't say that's always true for something like a syringoma or something like that. But whenever you get a large nodular adnexal tumor, like a hydroadenoma, something like that, there's the potential for malignant degeneration within the lesion. It's rare, but we always get concerned about that. And we often recommend removal of those because if you leave them in place for many, many years, they can gradually undergo malignant degeneration in some cases. So it basically takes the chance of that totally out of the equation when you get that removed. Okay, so we've got a number of neoplasms today, and in fact, I don't think we have much of any inflammatory process. There may be one or two, but anyway, it's okay. It's good to kind of bone up on your neoplasms. So here we've got an excisional biopsy, a very large specimen here, all the way down to the fats. You can imagine this isn't a shave or punch or whatever. They actually excised this lesion. And I'm not sure why they excised it. I can tell you that it's maybe painful to the patient clinically. And so maybe they said, this feels like a deep dermal nodule. Let's just kind of cut it out, be done with it once and for all. And obviously, they thought it was kind of a subcutaneous nodule. In this case, it actually is subcutaneous. It's sitting in here in the fat. And so they just said, well, we're probably not going to get out with a shave or punch. Let's just go ahead and excise it. So that's what they did. And there's a very, very good biopsy, obviously. And you can see you've got this round, again, well circumscribed, very symmetrical lesion in the dermis. It's got these cells that are somewhat bluish, purplish. They're not deep blue. They're kind of pinkish in some ways as well. So it doesn't look like it's non-epithelial, or it's certainly not spindle. If it's non-epithelial, it might be something like vascular or something along those lines. And some people consider vascular to be a variant of epithelium. So it's sort of, you can sort of think of it as closer to epithelium in a way than non-epithelium. And when you look at low magnification, you see all these red cells in here. And so when you see that and you see little small spaces, you should think vascular. You might go to higher magnification, say, oh, it's not vascular at all. It's maybe an annexal neoplasm with extravasated erythrocytes, but at least you should be thinking vascular. And so we are going to go to higher magnification. And lo and behold, you've got all of these blood vessels here. So it is vascular. And here's a large blood vessel at the periphery, which kind of goes along with that. And you got these large ectatic vascular spaces. So it is a vascular neoplasm. And then you start looking at it and say, well, are these, when you look at a vascular neoplasm, you need to ask yourself, well, what kind of blood vessels are we dealing with? Are we dealing with capillaries, venules, arterioles? Are we dealing with larger blood vessels? Are we dealing with blood vessels that have thick muscular walls to them? Are we dealing with blood vessels that are spindle shaped? Because that's one of the, even though we talk about fibroblasts, histiocytes, muscle, and nerve, sometimes blood vessels can develop a spindle cell morphology, like, for example, in capricious sarcoma or in angiosarcoma. Are the blood vessels irregular and jagged, or they sort of look like stag horns, elk horns? Those are important features to look for. What about the endothelial cells themselves? Are they large and plump and protrude into the lumen? Or are they very flat? Are they vessels that have little valves within them? Then we start thinking about lymphatics. And then we start looking for blood vessels that have these little small round clonal-like cells at their periphery, like we see here. And these are classic cells, glomus cells. And these are little myoepithelial cells, actually. They're not really endothelial cells. They're cells that are specialized cells. They have smooth muscle characteristics within them. If you do an electron micrograph on this, you see like little smooth muscle-like structures in there. And these cells actually, when you stain positively with smooth muscle actin, and the reason for these cells is that they're normally present in the small arteriovenous shunts that are present mostly in our fingers. And so we go outside and it's cold, and our fingers kind of get white, and the blood gets shunted back into your core. It's important to have your heart beating and your brain working, but your hands can get pretty cold, and that's okay as long as you don't get frostbite. So that's normal, the way the glomus bodies work in your skin normally. But just like anything else, sometimes those glomus cells can form a neoplasm. And in this case, they have formed a neoplasm. And so here, these little cells that look very, very much like they're clones or like identical. Just think of Star Wars, the Battle of the Clones or whatever. When you see these cells that look very, very similar to one another like this, you should be thinking of a glomus tumor, okay? And there's two types of glomus tumors. There's the type where you get lots of large ectatic blood vessels like we see here, and that's got the name glomangioma. That makes sense. It kind of looks like an angioma, but it's got the glomus cell component to it. And then there's the type that's the solitary glomus tumor that's usually seen in the acral skin, like often under the fingernail, very painful lesion. And that's a solid lesion. That's almost comprised just of a mass of the glomus cells, and you have to almost look carefully to see residual blood vessels there, because the glomus cells have replaced most of the blood vessels. So that's really primarily a tumor of the glomus cells with just a few residual blood vessels, almost kind of like a schwannoma, where you can see the spindle cell component of the schwannoma and a residual nerve twig to the side that the schwannoma came off from. Well, a solitary glomus tumor is kind of analogous to that. You see a few little residual blood vessels, and then you see the solid massive glomus cells that are associated with that. But this one is a glomangioma, which is more of an angioma that's got the glomus cells associated with it. So what's the differential diagnosis of lots of these little clonal-like cells that you see here, when cells look very much like one another? So this is one thing that you should think about. You can sometimes, some of the adnexal tumors, and some of the hidradenomas, for example, those cells can be very small and blue and cuboidal and can look very, very similar to one another that are not atypical. And again, there's really no atypia here. And mast cell lesions, those cells also can look very, very monotonous, if you will. Probably monomorphous is a better term, but the individual cells look very much like one another. There's not too terribly many diseases that you need to know about where the cells really look like little cookie cutter clones. But those are probably three of the most common. And when you see that, think about those various entities and then start looking for other criteria to help you make the diagnosis. Here, obviously, you've got the blood vessel, so you wouldn't confuse this with either a mast cell tumor or an adnexal tumor. Now, sometimes if you see the solitary glomus tumor, that can kind of look very like an adnexal tumor, like a hidradenoma sometimes. So in a case that's not clear, you can always do immunoperoxidase stains. And you should know, they might ask you this on the exam, what immunoperoxidase stain would highlight glomus cells like this, and the answer would be a smooth muscle actin stain. One other final sort of pearl, the blue rubber bleb nevus syndrome that you've all heard about. If you biopsy the blood vessel tumors in blue rubber bleb, sometimes they're glomangiomas. So they can actually have a lot of glomangiomas, and it's probably not really blue rubber bleb nevus syndrome. If they have that, there's a thing called multiple glomangiomatosis syndrome. That's probably what's happening in that situation. But the patient can look like blue rubber bleb nevus, and you biopsy it, and lo and behold, you see a glomangioma. So that might happen on occasion. And the glomangiomas, they can be painful too, but they're not as commonly painful as the classic solitary glomus tumor that we see on the acral skin where the glomus bodies normally live. Okay, this is an interesting entity. Another one that you're not going to see on the board examination, but something that we just wanted you to kind of be aware of. And here we've got a punch biopsy, and it probably clinically looked like a red diffuse area. And they probably were concerned about the possibility of maybe cellulitis or something like that. In this specific instance, they may well have been worried about recurrent metastatic breast carcinoma. So that may have been what they were thinking about here. I don't have the clinical information submitted in this case, but chances are it was probably one of those two things. Because the way this presents is a diffuse red area, pinkish red area on the breast, maybe a little indurated, but not always. And it's at the site of a prior breast carcinoma procedure. Often they've had surgery, usually postoperative radiotherapy, and then they come in with that clinical scenario, and then a biopsy is taken. And so what are you concerned about when somebody's got a red area they've had prior breast cancer at that site? Well, obviously those two things I mentioned before, but the other thing is an angiosarcoma. And we all know that the Stewart-Treves variant of angiosarcoma, we don't see that as much today, because really the reason that developed years ago was when they did radical mastectomies and cut out all the lymph nodes, and the patients get this massive lymphedema. And the chronic lymphedema would ultimately lead to the development of it's almost like a lymphangiosarcoma in a way, but it would be an angiosarcoma. And we just don't see that as much today because we don't do radical mastectomies with removal of all the lymph nodes. We give usually lumpectomy therapy with postoperative radiotherapy and chemotherapy. And a lot of patients now are living a lot longer with breast cancer without all of the destructive mutilating surgery that we used to do back in the 50s and 60s. So it's closer to a historical phenomenon, but you do need to know about it. This entity is far more common. Biopsy it, look at it, you're worried about a sarcoma, and you start looking, and wow, you've got all these blood vessels in here. And we just talked about the different morphologies of blood vessels in the glomus tumor. Well, here you've got some that are a little bit irregular. You've got some tufts of blood vessels here. You've got some dilated blood vessels that look like capillaries over here. Process is relatively broad. It's going from both sides of the specimen. Here's another one of these little vascular tufts over here. Go to the bottom down here. There's even some dilated blood vessels down here. And here's one that's kind of a little bit staghorn-like. And so you start looking at this, say, oh my goodness, does this patient have an angiosarcoma that's developed? Does this patient have Stewart-Treves syndrome? You know, they've been radiated for their breast cancer. They've had maybe a lumpectomy at the site, maybe they've had a partial mastectomy, and they've got this. Now they got a red firm area, and oh my goodness, we're worried about angiosarcoma. Well, the good news about this is that this is not an angiosarcoma. It's basically what we call an atypical vascular proliferation that's developed in a person that's had a breast procedure, usually that scenario. Usually they've had surgery, which results in some abnormality of the lymphatic and blood flow at the area. And then they've had radiotherapy. And both of those can be oncogenic stimuli. Radiation, obviously, we know can cause cancer. It's good to treat cancer, but it can actually cause malignancy in some cases. And then we also know that when you just get chronic stasis and blood, bad moral flow to the area, that can lead to our sarcoma as well. So you have to understand that this is not a sarcoma. It's a pseudosarcoma. I mean, it does have some histologic features that if you just looked at it in isolation, you might get kind of concerned about it. A lot of these blood vessels are somewhat irregular. They've got some slightly large endothelial cells. Don't see any mitotic figures. You've got this little sort of vascular tuft. We see that sort of tuft-like vascular proliferation sometimes in things like Kaposi sarcoma and whatnot. So, this when pathologists look at this, they start getting worried about it. But you need to understand this is basically just a reaction pattern that's seen in that setting. Now, it doesn't mean the patient's totally out of the woods. If you see a patient that's got this and you get this diagnosis back, it doesn't mean you just say, adios, we'll see you, don't ever come back and see us again. You'll live happily ever after. Because, it is, some people think it is kind of a potential pre-malignant process that can sometimes lead to angiosarcomas. And there are some case reports in the literature of patients that ultimately do develop angiosarcoma when they have this morphology. So it's not, totally something to just blow off if you see it. You want to follow your patient and make sure they don't develop something down the road that's more serious. But it doesn't fulfill all the criteria for angiosarcoma histologically or clinically. Now, what other entity might you think about when you see something like this? And there's another situation where we see usually in patients that have not had breast cancer. They may have had some sort of an injury of some sort. They often have pendulous breasts. You see them clinically, and they have areas of telangiectasia with an ulceration that might be have almost like a little whitish discoloration, kind of reminds you clinically of atrophy blanche a little. And then you biopsy it, and it shows this really almost prominent proliferation of blood vessels, sometimes with these little tuft-like structures that we see here, but mostly just it almost looks like stasis dermatitis or like acroangiodermatitis, more kind of like this type of change, although it's on the breast. And that's known as reactive angioendotheliomatosis, often seen in association with patients that have large pendulous breasts. They may have some underlying stimulus of some sort. A lot of them have a history of smoking. And so what we think of is going on here is that there's a compromise to the blood flow, and it's almost analogous to stasis dermatitis or stasis vascular proliferation that we see in the lower extremities. And so you'll see that on occasion too. And that's another item that's in the differential of this vascular proliferation that we see on the breast in that scenario. It's a little different phenomenon, looks a little bit different than this. This is more kind of a diffuse erythematous area that may be somewhat indurated. That usually does have the telangiectasis and also some ulceration. Okay. Another neoplastic process here. And you look at this and you say, well, how was this biopsy taken? We've had punch biopsies, we've had shave biopsies, we've had an excisional biopsy. Well, now we've got kind of the third type of, or fourth maybe type of biopsy that dermatologists take: punch, shave, excision, and then this procedure. And this is called an enucleation procedure. So this is where you see the patient, look at him, got what feels like a dermal nodule, and they say, well, this is probably a cyst. That's the number one thing that we think about. And so you're going to say, I'm going to take do a little nick at the surface of it and just kind of shell it out and pop it out. And that's what's called an enucleation biopsy. So that's kind of the fourth procedure that we do, and very commonly done with cysts and things of that nature. So whenever you see something that's enucleated and seems like it shells out, that's 99.9% of the time is a sign of benign. Usually it's a cyst, an adnexal tumor, or something like that. So it's almost always benign when that happens. Not 100%, but very, very common. And there's a reason for that. That's sort of associated with the lesion being well circumscribed. We always talk about things being encapsulated. It's often there's really not a true capsule, but it's actually compression of the collagen bundles at the periphery of it. Looks like a capsule, but it means it's a sign of well circumscription. It's well circumscribed. So cancer, the crab The cells intercalate between the collagen bundles. It doesn't remain, it's not well circumscribed in the vast majority of cases. So those don't shell out, whereas benign lesions do shell out. So once again, is it inflammatory neoplastic? Obviously, it's a neoplastic process. And what kind of differentiation is exhibiting? Well, it doesn't look like it's epithelial. If it is, it's some different kind of epithelium. It's not squamous epithelium. It may have some spindle cells in here as well, but it's got fat in here. So that's another non-epithelial, non-spindle cell type of non-epithelial process. And you see all these lipocytes in here. So if you get a benign neoplasm of fat, the diagnosis is a lipoma. Okay, so you've already made the diagnosis. You know it's a lipoma. So you're in the family of lipomas. So basically, thinking if you're clicking on your computer, you go to the drop-down menu and say, okay, what are some of the types of lipomas that we have to worry about here? And what are the criteria that we use to render the diagnosis? So we'll go to higher magnification, and let's see if we can see what kind of cells are in here. So there's about 5 or 6 different kinds of lipomas that you need to know about as a resident, okay? If you see abundant mucin and spindle cells in the lesion, well, that's known as a myxoid lipoma or a spindle cell lipoma with abundant mucin. Okay, so lipoma with mucin, spindle cell lipoma, or myxoid lipoma. Easy. Another lipoma, a lot of blood vessels. Sometimes the blood vessels look like little small cherry hemangiomas. We've got some blood vessels in here, but we don't have a prominent number of blood vessels in here. We don't see any little tufts of blood vessels with sort of clogged with erythrocytes. We've got some, a few blood vessels here with some erythrocytes in them, but we don't see the little tuft-like structures that we see that can actually be the predominant component with only a little bit of the fat left. That's an angiolipoma, which is one of the painful tumors of the fat. If we look at it and we see these large sort of bizarre cells that look like little flowers, florets, that's known as a pleomorphic lipoma. That's getting a little bit more esoteric and probably not going to be asking you about that. Here we've got a lot of fibrous tissue, lots of fibrous tissue. And if we see a lot of fibrous tissue plus a lipoma, guess what the diagnosis is here? A fibrolipoma. So it's yet another example of a lipoma. Again, maybe slightly esoteric, but it's pretty obvious here. It's possible they could ask you something like that. I kind of doubt it. It's a little bit kind of too banal and a little bit too more dermatopathology focused because it is a variant of a lipoma. But it's pretty straightforward, and this is a good example of that. And so we always talk again about non-neoplastic conditions. Non-epithelial neoplasms. Here you see the nice spindle cells here with the collagen bundles. So this is a fibrohistiocytic spindle cell component associated with the lipoma. So that's, again, one of the 3 main spindle lesions that we see. That's an example of fibrohistiocytic here, mostly fibroblastic. So this is a fibrolipoma. And there's a little bit of myxoid change in here too, so there's sometimes these lipomas don't like to read the textbooks. They say, well, I want to maybe bring a little bit of myxoid change in here. So I'm going to call myself maybe a fibromyxoid lipoma. But this is mostly a fibrolipoma. So it's just another variant of lipomas and pretty straightforward, not anything really to be concerned about. I doubt that they're going to show you this on the exam. If they're going to show you a variant of a lipoma, it's probably going to be an angiolipoma is my best. But you see it here. You've had a chance to be exposed to it. If they do happen to show it to you on the examination, well, you'll get it right. So easy peasy. Okay, good. Now we got an inflammatory process. So I like inflammatory things. I think it's fun. You can apply criteria and, basically we can arrive at a differential diagnosis here, and then you correlate the clinical, and it's very rewarding when you can make a definitive diagnosis for your clinician and your patient when you can do that. So here we've got a beautiful punch biopsy, gorgeous, nice biopsy that we love to see. So this is exactly the kind of biopsy we like to see for inflammatory skin disease. Do not like to see shave biopsies. And people that don't get trained in dermatopathology. And unfortunately, a lot of those are our physician assistant colleagues I call them colleagues because they are collegial and they do good work for us and we like them, but they're not trained in dermatopathology. They get zero dermatopathology in their training. It's a massive deficiency that they really needs to be rectified. We try to educate them as much as we can. As you know, being a dermatology resident, the best place to get that education is in your training. It's not after training because you're too busy doing other things when you're finished with your training. So you really need to get it in your training. It really should be part of the PA training. They really shouldn't be allowed to practice dermatology unless they've had some dermatopathology experience, and it should be a relatively rich experience in their training. So unfortunately, we're not at that stage yet, but that's something that hopefully eventually will be included because we get shave biopsies like this from people that don't understand that you need a punch. And you know that you need a punch biopsy for this because you need to be able to apply the criteria. And one of the things we look at, first of all, it says an inflammatory neoplastic, obviously inflammatory. What's the pattern? Superficial and deep perivascular inflammation. If you get a shave biopsy, you're crippled right out of the bat. We can't talk about whether it's superficial or deep. You can only talk about whether it's superficial. So, we had a biopsy the other day sent to us as roulette lichen striatus with a shave biopsy. Well, you can't diagnose lichen striatus with a shave biopsy. It's possible to do that. Can't do it. So you shouldn't submit that with a shave. You should know that you're never going to get a diagnosis of lichen striatus. You don't take a punch biopsy because you need to see if there's periacrine inflammation. And the acrine inflammation is down here. So unless you know that, you're not even going to know that you need a punch biopsy. So that's part of the problem. Some people don't know what they don't know, and they submit something that's a waste of energy, time, and money for the patient. It's a total waste. And part of our goal in practicing dermatology and medicine should be to eliminate waste. So that's wasteful, and you don't want to be wasteful. So I'll get off my soapbox and we'll go back to the diagnosis here. So we say it's a superficial deep infiltrate. What kind of cells are in this infiltrate? And at low magnification, these are dark jet black cells. They're dark. So they're going to be lymphocytes. We don't even have to go to higher magnification. We know they're going to be lymphocytes. And at this power, we say, well, this puts us in the category of the lymphocytic infiltrate pattern of inflammatory skin diseases. And we have a mnemonic device for those. We use the letter L, and some people talk about the 5 L's. We add a few extras, and there's actually another one that you can kind of put in there that we'll talk about in a minute as well. But it's a lymphocytic infiltrate. So low magnification, once you've got that, the idea is the reason for making a preliminary first impression low power diagnosis is to, when you go to higher magnification, you're not all over the map. Okay. So if you want to go, to Walmart and you put the thing in your phone, it's going to give you pretty specific directions on how to get there. If it gave you 20 different options and it sort of said, there's a bunch of Walmarts here and this will kind of get you to one of them, and you really wouldn't be able to kind of be more directed in your approach. So that's the reason. We look at a low magnification, this is lymphocytic infiltrate. I'm not going to think about vasculitis here. I'm not going to think about paniculitis here. I'm not going to think about scleroderma and all these various things. I'm going to think about the lymphocytic infiltrates here. So that's why we do it. You're not going to be wasting a lot of time when you've already kind of honed it down at low magnification. You're going to think about the 5 to 7, 8 L's, if you will, that give you lymphocytic infiltrate, and see if you can apply secondary layer criteria to help you make the diagnosis. So we start asking ourselves, if it's a lymphocytic infiltrate, is there any epidermal involvement, for example? Is there any interface change, like we might see, for example, if it were lupus, possibly? Well, we look up here and there isn't much of that. Is there any mucin in the dermis? The tumid form of lupus erythematosus, that can give you mucin in there. That's helpful. That would be, would favor that diagnosis. Is there papillary dermal edema up in this area? If there is, that might favor polymorphous light eruption. We don't see that here, so probably not that situation. Do we see plasma cells associated with the lymphocytes? If we see that, that kind of tends to favor Lyme disease. And again, another L, differential diagnosis. We don't really see too many of those, so we probably wouldn't think of erythema chronica migrans here either. If it's sort of non-specific and all we see are just lymphocytes with no epidermal involvement, no mucin, anything else like that, we might think of one of the gyrate erythemas One other kind of like deep gyrate erythema annularis centrifugum, that can be associated with underlying cancers and whatnot. We might think of an unusual variant of a leukemia or lymphoma. We want to throw that in there. Unlikely in a situation like this. Sometimes pernio, that's not an L, but you can kind of think of it as maybe, something that would have an L associated with that if you want to throw it in there, but it's maybe not enough heat. You get cold and freeze, and so that can give you some changes like this. Usually we'll give you a little more interface change for that. And then lupus, not tumor but sometimes the chilblains form of lupus erythematosus can give you this. So, those are the main ones. Sometimes Hansen's leprosy can give you interterminal Hansen's disease. There's a list of them. Louis obviously can do just about anything. You get plasma cells with that also. So again, this is one of the lymphocytic infiltrates. In this case, we thought this might have been related to cold. It had a pretty good history of maybe being kind of a pernio-related process, but that's not the most important point. The most important point is the working through the differential diagnosis. And then when you look down on your multiple choice selections, you say, they've got the tumid form of lupus in here and there's mucin, so boom, that's the right diagnosis. So that's the way to do this. That's how you go through an inflammatory skin disease like this. A beautiful example, a very, very nice biopsy. They didn't crush this. They took a gorgeous biopsy. Those are the kind of biopsies you want to take. Okay. I've got another example here of a neoplastic process. Okay, another excisional biopsy. They took the entire thing out. I don't know if they maybe had taken a prior biopsy and they couldn't get it out of here, but they took the whole thing out. It's a gorgeous biopsy. Once again, you can see low magnification. It's epithelial and it's non-spindle. It's an epithelial process. It looks pretty symmetrical. It's pretty small. It's well contained here. We can draw a line around the whole thing. Looks benign. Okay, so we're going to do the same thing we did here when we looked at the Syringocystadenoma Papilliferum. We looked at the Trichoepithelioma. We looked at all these various neoplasms today. We're going to look and see what kind of differentiation is exhibiting. So small, symmetrical, or circumcised, benign, epithelial. What kind of epithelium? We're going to look and see. And we've already seen this epithelium twice today. So you're kind of getting a theme. So if you look here, you can see once again, it's apocrine differentiation. Apocrine. So we've seen a Syringocystadenoma Papilliferum, which is an apocrine lesion. We've seen a Nipple Adenoma, which is an apocrine differentiation. And now we've got another apocrine lesion. But this doesn't look like the Nipple Adenoma. This doesn't look like Syringocystadenoma Papilliferum. So what is this? So you've gotten into the apocrine category. Now you got to give it a name. So we've, hi, glad to meet you. What's your name? Yeah, okay, so we're going to give it a name. And if you look at it, the name of this entity really fits quite nicely. The name of this is called Tubular, and these look like little tubes. Apocrine, we just identified the apocrine decapitation secretion over here. Tubular apocrine adenoma. Adenoma, okay, it's an adenoma because it's a benign adnexal neoplasm that's glandular. So some of the lesions that got named by our ancestors that first looked at these things are good names. Some of them, maybe they kind of missed the mark a little bit, but this is one that's beautiful and is gorgeous, and it actually fits. Tubular apocrine adenoma. So if you see multiple little small individual cyst-like structures that are apocrine, and you've got these apocrine differentiation in here, and it's a small, round, well-circumscribed lesion, so it looks like there's a bunch of tubes with apocrine differentiation, that's the diagnosis. If they put hidradenitis papilliferum here as a choice, do not choose that. Okay, it has two features in common with that. It's endophytic, it's in the dermis, and it's got apocrine differentiation, but it doesn't have the papillomatous configuration, and it doesn't have the plasma cells. It doesn't have the features that we saw before with the Syringocystadenoma Papilliferum. So don't choose that. They might, that's getting a little bit sort of tricky, but it's possible they might say, well, we want the best diagnosis here, and we don't want, someone to choose the wrong diagnosis when it's really better to call this a tubular apocrine adenoma. because it's a perfect example. So they're going to show you something like this. It's a little bit weird. It's going to be like a, textbook, beautiful case of it. Okay. Another lesion that was removed by an incisional biopsy, by like a enucleation. Okay, and this is probably one that you're less likely to get on the board examination, but we're showing you some of these different differentiations again. And you see at low magnification, it's got mostly stromal changes with some epithelial. The last one, everything was epithelial with minimal stroma. The Trichoepithelioma had a lot of stroma with a lot of epithelium. Here we've got mostly stroma with a little bit of epithelium. So this has got some epithelial component, but it's largely non-epithelial. And as we go to higher magnification, once again, fibroblast and histiocytes here, collagen plus spindle cells equals fibrohistiocytic 99% of the time. Okay, so that's basically when you see that. So it's got a fibro component. Now, once again, we look at this epithelial component, and you see these little small glandular structures. They look like little reticulated glandular structures. They're kind of forming these network-like structures throughout the lesion, and they're also lined by this apocrine-like epithelium here. This actually came from the breast, interestingly enough. So it came from the breast. We already talked about the breast being an apocrine gland that sort of just got massively large. So it's also apocrine. So here we've got what's known as a fibroadenoma. Fibroadenoma, and it's a lesion on the breast, quite common. Totally benign lesion. This is a classic example of it. So it's, again, another apocrine lesion, but it's got mostly fibrous tissue with relatively little glandular epithelium. But these glands look like this. They look like these little irregular networks of glandular structures that are kind of coalescing and forming these little, it's almost like a neural network, if you will. So these things are like communicating with one another throughout this big sea of fibrous tissue. Highly unlikely to appear on the board, but we're just kind of introducing it to you and just showing you. Okay, this last one, we'll just kind of go through kind of quickly. Inflammatory process, once again, punch biopsy, good example. Superficial and deep perivascular infiltrate. So this is, again, a superficial and deep perivascular process. Also low power, you can see it's also interstitial. So it's not purely perivascular. Lymphocytes, but maybe some other cells in here, because not everything looks jet black. Minimal epidermal involvement. Minimal epidermal involvement. And as we go to higher magnification, we've got mostly lymphocytes, eosinophils, some plasma cells in here. And this is mostly a dermal-based process. Okay, it's fairly diffuse, fairly diffuse. You're probably not going to get anything like this on the board examination either, because this was actually kind of a challenging diagnosis that we had. But basically, in this case, this was an individual that had an insect bite reaction at this site. The thing persisted, and then they started getting symptoms that were sort of analogous to Lyme disease. So you can see this thing maybe starting to kind of appear like a little bit of a lymphocytic infiltrate here. Goes down into the fat, okay? But it's also interstitial, so it's not like one of the classic lymphocytic infiltrates. And this also has some plasma cells in it. So this is what you see when you biopsy somebody that's got Lyme disease or has the so-called STARI syndrome, which is basically like Lyme disease. It's a Borrelia disease that they haven't really identified the Borrelia yet in the southern part of the United States. And if you biopsy like the bite, the hit site area, it often looks like this. So this is more just kind of interest for you. You will never see anything like this exactly on the board examination unless they gave you a lot of information, because it's just too esoteric. But it's a nice example of a pattern. It's a diffuse infiltrate, superficial and deep, perivascular and interstitial, and eosinophils in it. So you can see it's kind of beginning to form a lymphocytic infiltrate here, but it all still has the residual sort of bug bite, like tick bite reaction that occurred where the site, probably was the hit site, where the lesion developed. Okay, hope you enjoyed that, and thank you for listening. And